Okay, thank you. No direction, but does anyone know what this study is here?
What is this?
So this is something that every radiology resident knows and dreads well. This is a voiding defecography study. So what we do is and thank God I didn't specialize in GI, but you take barium, and this is a lateral view of the pelvis. You take barium and you inject it, and you then fluoroscopy while the patient's defecating. And nobody wants to do this, but some people need it. Yeah, so you actually in the fluoro suite.
That's why you're doing what you are doing now.
Exactly. And so what you do, and it's done for a very important reason, which is you can get rectoceles, people that have dynamic obstructions in the rectum. And so why am I showing you this? Well, I wanted to tell you a story. So I went to the radiology residence graduation party in May, or maybe it was June, and I was on call, so I got there in the evening a little late, and I sat down right before the speeches, and I sat next to our former chairman's wife, and they had come to Boston from the Midwest, and she was a technologist, and he was I think a nuclear cardiology kind of guy, new med guy, and long story short, they're both retired now, but she turned to me and said, "Oh, you do cardiac, right?" And I wanted to tell my sister just had an MI, and she started telling me it was really very concerning. And then the speeches started. So our story was interrupted, and during the ceremony, we always at the end of the year kind of have some the first year residents kind of poke fun at the staff. And probably because by the time they're seniors, they really have some mean things to say. But so generally, people don't meet us in the cardiovascular section because we're more of an advanced rotation. You got to know the basics before you get to us. So I was always kind of safe from getting ribbed at. And but this year they put my picture up, and then they had a sketch, and one of the residents was playing me, and they showed a CT angiogram, and they showed me saying, the guy playing me said, FMD, and they showed another CT angiogram, and Brian says FMD, and they show the next one, Brian says FMD, and then they show a chest X-ray, Brian says FMD, and then they show a sonohistogram, an ultrasound of the uterus, Brian says FMD, and then they show a defecography, and Brian says FMD. And so the fact that, and at first I was like, wow, I'm no longer safe. And then the second thing I realized, this is awesome because the message is out. Because I don't think that we were making that diagnosis enough just a couple of years ago. And it's no good if I come here and go to this fancy conference and talk to all the elites, and I can do it, but nobody else can. And so I'm so glad that now our first year residents actually know that FMD exists and that SCAD exists. Because it does not just happen in downtown Boston and downtown Vancouver. It happens all over. So then I sat back down. Oh, and so, of course, our former chairman looks at me. I look at him. Well, he's like, there's no publicity, but there's no publicity is bad publicity. So then his wife starts telling me the story, and he kind of leans over too. So his wife's sister, and she's into her 60s, I guess, but her sister had lost her husband. And at a time of stress, and what she said, it just was so unfortunate because just within days of losing her husband who had a cancer, and she was in the hospital already visiting a lot, she ends up in that same hospital having a heart attack, and they couldn't find any plaque, but then something tore, and these guys aren't savvy with cardiac cath lab lingo, and it's all very oblique, so. This guy's a retired chairman. He'd been chairman for 25 years. He showed up in my office a couple days later. I had offered if you want me to take a look at records or if you want me to connect you with Dr. Wood or anything, because it just sounds kind of like a SCAD and maybe she has FMD. So, and then he chuckled. So a few days later, he shows up with a pile of discs, and we looked through in my office, and it exactly was that. It was a iatrogenic dissection propagated by attempting to stent. And the correct thing we would know at our cath lab is make the diagnosis and stop. And certainly in the setting of acute MI, I think it's very reasonable to start with a cath. But that outside hospital in the Midwest hadn't been to this conference and hadn't heard about it yet. And so I think part of our role here is to remember that it's a team sport, and so we need to all go out and communicate all of what we know. And if that one little factoid about the best thing is not to stent and to stop right there, it would have been known. It would have saved her. She actually it was a worsened event. And so I'm glad to be here with all of you. I know I'm kind of in the minority as a non-cardiologist speaking, but I think it's all the more important. So I have to confess, Dr. Saw, I didn't finish my slides before I got on the plane. So I think it was before dinner last night. I don't know what time. I'm going to be proven a liar by this slide. So whatever it was, I went on my Facebook page, and I don't go on very often, but one of the residents had tagged me. And so Shadi, who's I think a second-year resident, said, "Hey, Brian, you would like this case. The Society of Abdominal Radiology showed this case, and it was FMD, and we all nailed it right away." And so that was kind of cool. And you can actually see the answer for last week's is indeed FMD. So I guess everybody got it right, and we'll give you a more challenging case. So I think this would have been a challenging case for some people a couple of years ago, but not for my residents on my watch, and everybody knows. And so just highlighting the point that the message is we're not done yet. For sure. So I'm going to, we've talked about all this stuff almost ad nauseum, even Sanjay's talk kind of went over it too, but imaging and investigation for predisposing arteropathies. So what are we looking for? What findings are going to be helpful? When not to look? And indications for imaging. Why should we look? Does it make a difference? Where should we look? Which vessel beds to image? I think you already know the answers to most of these. And then how should we look and what modalities, some protocols, some technical stuff. I know most of you aren't running CT scanners or MR scanners or echo labs, so I'm not going to get too into details, but I'm going to give you the tools and show you where to find them. So what are we looking for? What's helpful? Well, you've got the consensus criteria on fibromuscular dysplasia. That's the big elephant in the room. There's a lot of other things. And I actually think, and some of the people on this guideline document think that FMD may be actually just a complex of diseases we don't fully understand. And so just a couple of highlights from that. So consensus point they came up with, number one, is that arterial lesions of FMD should be classified according to angiographic appearance as focal or multifocal. Number two, if a patient has a focal or multifocal in one vascular bed, to establish the diagnosis, the presence of aneurysm, dissection, or tortuosity in another vascular bed is considered multivessel involvement of all affected vascular beds, right? So if you find that splenic aneurysm, you might want to go and look further. The presence of at least one focal or multifocal arterial lesion is required to establish the diagnosis of FMD. The presence of aneurysm, dissection, or tortuosity alone is inadequate to establish the diagnosis. So, the most specific thing you can see is beating, but not everybody with this. I think even if it's not FMD, is there arterial fragility. So, finding abnormalities matter. There are currently no genetic tests that are specific to FMD. There's no justification for genetic testing of asymptomatic relatives of patients with FMD at this time. Pending future genetic developments, relatives of patients with FMD should only undergo a clinical examination. And I think the idea is that you just don't want to get a shotgun approach to everybody. And imaging-based evaluation of potentially effective arterial beds upon presentation with suggestive symptoms or signs of FMD. So basically, we should be smart about it. Now, there's a lot of mimics and there's a lot of alternative diagnoses. They list them all out, and I'm not going to relist them. But I also note SAM. If you go back in the literature, the first publication of SAM in the New England Journal posits that it's a subtype of FMD. I believe that to be true. It's I think they're all subsets. FMD is common. I'll get to that and exactly how common in just a second. But you don't want to be faked out by imaging findings like standing waves or imaging artifacts. Somebody sent me a case from an outside hospital in town the other day, and it looked like an SFA occlusion, and it was a vascular closure device causing an artifact, so you could not see the SFA ostium, and everyone's doing closure devices this day, but on an MR, you don't get signal in your metal. So, no, you have to be an expert imager to really not be faked out by artifacts, and if your suspicion is up, you might say, hey, look, it's FMD, and it's even affecting his SFA. Okay, so Takeyasu is all the inflammatories. I showed a case this morning where it was a difficult, differential when someone already had a lot of vasculitis or potential inflammatory disorders. And then a bunch of other stuff, even nephrogrammastosis. And of course, we've talked about Loeys D to Ehlers-Danlos. Okay, so let's say you've seen this slide yesterday. Concomitant FMD seen in 50% of SCAD patients. And in our little study at our registry, we found some abnormality, not specifically FMD, but some vascular fragility marker by imaging in everybody that we imaged with a wide screen, getting from basically, as it was phrased, brain to pelvis, or I call it head to pelvis. Here's a case that I showed, but you can see actually a dissection of the celiac artery. The better the scanners get, the more we see these. Still a little bit bright here, but you see there's a linear line right down the center of the vessel. And these don't always obstruct, and sometimes we just pick them up incidentally. This person also had end organ damage. They had a renal FMD and a renal infarct, and so sometimes looking at the end organs, and the very classic here, infarct in the kidney. So it's really not a big leap to say you have vascular abnormalities. No, the other thing to remember is that you have to be searching and read with an eye towards this. This isn't flagrant. It's not the biggest renal infarct I've ever seen, but in the setting of a very sick patient with other dissections, there you have it. Neurovascular imaging can be done with CT, MRA, and invasive imaging. I've seen a lot of things missed by invasive angiograms because a lot of practitioners are getting into the cerebrovascular space, and I think they can be subtle. So one of the benefits of the non-invasive is that you can kind of sit there and look at it afterward, and you can pound it into your residents' heads, and so things get picked up more and more. And everybody that's looking at vessels hasn't had the chance to drink the Kool-Aid with us. Okay, so how about when not to look, and when not to look, and what are indications for imaging? It's very prevalent. And staying on FMD, we used to do invasive angiograms for everybody that was a renal donor. So this is kind of a screening of normals kind of situation, which doesn't happen with invasive angiograms anymore ever, and really didn't. But in people that are donating a kidney, you want to make sure there's no vascular abnormalities. These days, you're getting a CT or an MRA. But not all that long ago, we were doing invasive angiograms. I remember in med school rotating in interventional radiology, and it was I think at the University of Pittsburgh, and Dr. Kareem was the transplant surgeon. We had a Kareemogram, and you would inject every single vessel bed because he needed to know, I'm going to transplant a liver, I need to know every vessel connection, and I want to know if there's anything incidental to a fine. That was a pretty intensive process, and now it's a 1.5 second breath hold, and you're back on with an IV placement, that's it, and much less contrast. But these careful review of these studies showed that in asymptomatic people showing up to donate a kidney to someone else, I've seen reports of 3.8, I've seen reports of 6.6, even as high as almost 10% arterial abnormalities, most of which are FMD. So you can kind of presume that there's a general rate of FMD in the general population, somewhere around maybe 5%, maybe more. So the substrate to dissect is in a lot more patients than we thought. In fact, there's a lot of these rare diseases things, and people wear the zebra caution. I don't really think you can call something rare when 1 in 20 of us has it. And I know in this room we have a little different prevalence because we're selected. But I work in a big reading room in radiology, and I tell all the residents somebody in this room has FMD, and I said that enough, and then one day a senior colleague who had just retired and I'd worked with for years showed up for an MR, and I never knew, and he never told me. He was a different subspecialist, but he had FMD in renal dissections. We've been following it for years. It was just my day to read when he came through, and I was like, oh, well, that totally corroborates the 1 in 20, because we had about 20 folks in the room every day. So there's no guidelines for when you should image, and appropriate risk criteria are not probably going to have that because it's a fairly new predicament, and it's not as common as some of these things like renovascular hypertension. So the guidelines will tell you if you're looking for renal artery stenosis, and this is a stenotic disease, MRA and CTA are top of the line. It actually puts, for people with low EGFRs, to put ultrasound, Doppler ultrasound of the renal arteries first. I'm going to caution you though, I've read ultrasounds on people's renal artery dissections back-to-back with their CTs, and the ultrasound's negative even in retrospect, even with me in the room scanning, and then you can see the dissection on a CT scan. So it's a little different than just looking at these more classical types of things. So renal ultrasound, fair enough to start with, but it's only helpful if it's positive. If it's negative, it tells me nothing, and even in the best of hands. I would also say that CTA is better than MRA for FMB. I do all three, and I consider myself an expert in all three, because I don't do all the other stuff. The reason CTA is better is calcification. In general, FMD never calcifies. Sometimes you'll see it very late, and I also see a lot of old calcified folks that are coming in for TAVR. I should say elderly, I guess is the right word, but I see a lot of folks that had a dissection long ago, and now they're healthy, and they lived a long and fruitful life, and they've now calcified the aortic valve, and it's time for TAVR, but you can see sequelae of FMD. So, FMD is often something, it's just it's a step along the way, and it's also, I think, something everyone with the disease needs to know. Is it's not something that you need to consider it's going to create a difference. It depends on your acute setting, but you can live with it for quite a long time and maybe even never know you had it. It's also the other thing about CTA I love is it's a lot easier to get a great CTA, and you need great imaging than a great MR. That expertise is a little closely held. It takes a lot longer to do an MRI. You have to have a coil for each body part. So if you want to do the carotids, that's fine. Then you got to go and move the coil. So you can end up doing 3 or 4 exams worth of imaging to get a careful MRA of every body part, whereas a CT, it's a second and a half, stem to stern. Okay, so those are practical considerations, but very important. Okay, why should we look and when does it make a difference? I just want to show you this case, just on the question of FMD. I don't know if they've read a SCAD, but it was a 50-year-old woman with innumerable admissions and appendicitis rollouts. So she had right lower quadrant pain over and over again. She had been all over the country and showed up to the head of our vascular medicines clinic, and he auscultated a bruit and asked for a CT. I read it as negative. This is like 10 years ago. He called me and he said, "Brian, just like, I can't see anything else it could be. I've turned to every stone." And so he came down and we looked together, and wouldn't you know it, he's written the book on this stuff. He's famous, but I remember reading his papers, and the dogma is that FMD can happen in any vessel except the aorta, and there's certain ones you're going to see it more commonly, renals, carotids, that kind of thing. And there it is. There's her thickening, and it's a beating of the right internal iliac artery. That's the artery that supplies your right ovary. And if you have ovary pain, it's going to give you right lower quadrant pain, which, everyone thinks of appendicitis first. And if you do a GI protocol CT scan, you're going to, be looking for appendices and not for small, tiny arteries. But and you can see this is a couple of years ago, but not as great image quality, a little larger patient, but beating, aneurysms, serial beating. Let's MIP that up, so maximal intensity projection, make it more like an angiogram in the cath lab, and you can see very clear sequelae of FMD, even some stenosis in that right renal artery. So right renal artery, FMD, dissection, and aneurysm mimicking appendicitis. So you can literally see it in any vessel in the body. In that you could actually look higher on the scan, and okay, there's some, it's a ptotic kidney and it's a little bit beaded, and maybe I kind of undercalled that, so I learned to adjust my threshold on that case. It was very informative. Also, I see some iliac artery aneurysms here, so stuff that is a generalist I didn't know, and as I became more of a specialist, I did. Now it's my job to tell everybody, and for you to tell your friends, right? It makes my blood boil here. Well, the radiologist in my department can't do it. Well, tell them about this. They're not. It's somewhat rarely found these days, so talk to them, engage them, and it's something that's teachable. And we're talking first-year residents now, seeing it when we hadn't before. So be an advocate locally. Okay, where should we look? Which vessel does the image? Well, any vessel except the aorta is FMD, but you already heard it talk about the aorta can be very abnormal in some of these other alternative diagnoses, so don't stop and not look at the aorta. By the way, I have seen FMD affect the aorta because somebody had an iliac artery aneurysm and dissection, and it retrograde dissected into the aorta. So I've seen the one exception to the aorta rule. So don't ignore it. It's you can't image them image one without seeing the other. But the other thing is genetic orthopathies, and so the point was already made, but look at sizing of the ascending aorta. That can be easily ignored, especially borderline sizes. So you might have to index it, especially in a child. This is somebody with Murray syndrome. I think I'm saying that right. Honestly, I don't really know. It's very rare, but that you can see actually mid-aortic narrowing, and they're predisposed to vasculopathies. It happens in children. It's it's one of these genetic, I think it's SMAD4. I don't know. I'm just trying to impress you. I don't even know what that is. Okay, so how should we look? And I won't get too into details because I think it's not the right crowd. But happy to help. Come up to me afterward, shoot me a tweet or whatever, and I'll happily give you our protocols, and they're all published anyway. But so when we're looking at the heart and the arteries at the same time, we do a scan. We started with TAVR, but we can do it for anything now. So we do an ECG triggered or gated scan over the heart. Same breath rate, same bolus. Keep the contrast running. Move the scanner up and scan head, neck to pelvis. That works if you have a fast scanner. So more modern scanners do this handily. Some older scanners can't do that, so you might have to do a gated scan of the chest and then move down. I don't love this type of brand of scanner because it involves more radiation. You're gating the whole chest. But if that's what you got, it's what you got. But we reserve this for that former scanner when we're using young patients. For TAVR, it matters less. They're elderly. The radiation risk is a non-issue. But for our younger patients, I stick them on the Ferrari scanners and get that done. And then the other thing is cardiac experience helps if you're doing gated scans. This is somebody that was coming for a TAVI scan, so transcatheter aortic valve implantation. But they breathe. There's some slabs. You can still read through it. It's not the end of the world. But ideally, if you're going to do this, there's a good synergy between techs that can do cardiac imaging and advanced vascular imaging and this. So 2 ways to do it. The other thing you can do is do low dose scans. So I don't care if you have some renal insufficiency. We don't have a lot of evidence to say we're going to hurt you. Some of the Eric Williamson's at Mayo Clinic did a really big registry and looked back. Basically, people where we were too fearful of contrast and nephropathy. So especially with small doses, and we've seen this, and we have the data. I've seen it now with the TAVR, where we'll really need to inject you because we'll spare you contrast in the cath lab. So you can certainly do this. This is a woman that had 20 cc's of contrast with an ultra-fast scan. So not every scanner can do this, but you ought to have access to one in at least every town. So even if your kidneys are failing, I will inject you. I've never caused renal failure. And you're going to say, well, you found like a small, short person and you injected her and got this pretty picture and you published it and you're biased. Nope. I do it. This is just 4 successive scans off the PACS right before I left. You can get a whole body CTA with the right setting and the right operator. So you have to have some expertise. They can read our paper. It's a recipe. You can do it. Every once in a while, we outrun the bolus and we go back and get the legs. So you don't need to go on to more advanced testing if you can get a great CTA, like all of these patients. Okay, if you're going to add in the neurovasculature, it's harder to do that all at once. Split the bolus, put the arms up for the body, and put the arms down for the head and neck, because arms are meat, muscle, bone that blocks x-rays, and we need every photon we can get from the x-ray machine, and we can use less of them to image. So there's a little bit of nuance. We'll do it the same day, because the contrast can get so low now. With even just maybe 100 cc's total, we can get you everything. But I don't think the patient should have to come and go, but it involves the radiologist or whoever's doing your imaging. Cardiologists can do this too, to get to the scanner and tweak the settings. So it's very important to ask for that. And they might say, well, we can't do that, but you got to ask. MRA is great, but MRI can see air, calcium, and tissue next to metal. So that guy with the implant, it's going to look like an occlusion. It's not. The other thing is calcium. And calcium is a good distinguisher between SCAD and CAD and between FMD and atherosclerosis. Here's a nice MRA. You can do it with contrast. There's beating and renal stenosis. These are non-con images here. I just showed the pelvis. We were trying to work out, a renal transplant. But you can do MRA with no Gatto. It takes a little longer, but if you didn't tell me, I would have thought that's a really nicely timed bolus with Gatto and beautiful MRA. So it can be done. It just takes longer. Okay, key points. Careful CTA is, in my humble opinion, the most ideal. Image as many vessel events as you think is needed, and let your clinician guide that. Doppler ultrasound is helpful only if positive. Don't believe in negative. It can be a false negative. It often is. MRI is good, but especially for follow-ups, but there's some caveats. And most important than all of this, SCAD care is a team sport. Get out there, spread the message, grab whoever my counterpart is at your hospital and get them on your team. If you're at this meeting, you're on the team. Okay, thank you.